So today I'm going to be talking about migraine, and I have a special interest in migraine. Just mainly it's a personal interest for myself, my daughter, my mother, my grandmother. It runs in families, and I'm constantly trying to find out more about it because the more I learn, the more I realize there's so much more to learn. And recently I've connected with Joe, who's got a medical background, and he's got an incredible amount of knowledge about migraines. So I am literally going to pick his brains. And just thanks for coming to share some of your knowledge.
Happy to be here. Very excited.
So I think I reached out to you actually because I was reading your information, which is incredible. And there's a lot of misinformation out there, a lot of confusion. And some people just think migraine's a bad headache, which it isn't. And we can talk about that. But I'm very interested in the role of hormones and migraine and what happens when hormones change, and does it have an effect on migraine, and do giving hormones back have an effect? So these are some questions that I'm really keen for you to answer and just to talk through. But before we start, can you just explain to people that might not be so sure what migraine actually is?
So migraine, as you stated, is not just a headache, right? A headache is one phase of a migraine attack. Migraine itself is a chronic neurobiological disorder. So migraine is a disease like asthma where you have the umbrella term, and then you have the exacerbations, which are asthma attacks. So you would have migraine attacks, and migraine attacks consist of generally prodrome phase, then you have the aura phase, then you have the headache phase. So the headache phase is one part of the migraine attack, and then you have the postdrome phase afterwards, and then the interictal, or when you reach back to baseline. And that reaching back to baseline, not everyone goes exactly back to baseline. There's obviously some people, especially with chronic migraine, there's lingering symptoms between attacks, but in general, the headache is only one part of a migraine exacerbation or a migraine attack. Mainly, it's a neurological disorder. It's a primary headache, which means nothing else can cause it. If someone says, oh, it's dehydration, drink more water, well, that would be a secondary headache. It's a headache caused by dehydration or something else. So if you have, for example, someone with meningitis, one of the symptoms is a headache. So a viral infection or a bacterial infection can potentially cause a headache. That's a secondary headache. What we're talking about with migraine is a primary headache. And we have cluster headaches are also primary headaches, and tension type headaches are also primary headaches. So these are headaches that aren't caused by anything. They're just based off your biology, your genetics, and just your anatomy.
Yeah, and that's really important actually for people to understand. But actually, some people don't even get headaches, but they still have migraine, don't they?
Right, exactly. So you can have a migraine attack without the headache phase. It's absolutely unnecessary. You could just have the aura phase. And that's actually very common in the menopausal uh, uh, demographic, where they actually if they develop migraine at that stage, they generally develop it with an aura without a headache, or less of a severe headache form, which is very interesting.
And a lot of people I see have vestibular migraine, so it's their balance that goes, and sometimes their coordination. Well, quite a few people have been admitted to hospital with a question mark stroke because they lose speech. Maybe they get drooping of the mouth. They might get weakness of the arms, and sometimes associated with a headache, like you say, or sometimes not. But that you can get these other symptoms, can't you, when you have a
Right.
migraine?
So it's for hemiplegic migraine and MUMS as well, which is it's still not officially recognized, but it might be soon. It's hopefully for ICHD4. Right now, we're just dealing with ICHD3, kind of very old, but that's what we have. With hemiplegic migraine, you have motor symptoms, and you show up to the emergency department, or in the UK, the A&E, and they'll think it's a stroke because you have motor weakness. So unilateral motor weakness. So the head pain, and you might have ptosis as well, or other things suggestive of a stroke. And so over time, you learn this is probably just my migraine attack, but hemiplegic migraine is something that you don't want to expose someone to constant CTs every time they have a hemiplegic migraine attack. So yeah, so this also goes further into how migraine is not just a headache. You have motor
Mm.
symptoms.
Yeah.
And generally with headaches, you don't have you don't have these other symptoms that are part of the aura phase. Well, in regards to motor, it would be it's called an atypical aura rather than just a regular typical aura, but it's still part of the aura phase. You don't have these symptoms with just a headache. You have it with
Mm.
a neurological condition, a neurological disease.
Yeah. Yeah, and I mean, I know myself, if I'm going to have a migraine, I often feel quite cold and shivery. I yawn. I might feel tired. I might feel more hungry, even though I've just eaten, maybe. And but my brain just doesn't function in the same way. And this is where I think thinking of it as a neurological condition, and actually the pain of my migraines is often on the left side, but it can be on the right side. But that isn't. Sometimes it can be the worst thing ever. I have felt sometimes I've had a knife in my head, but often it's the other bits when your brain can't work. It's really hard, isn't it?
Right, absolutely. So what you're describing is much of the prodrome phase, where you have these mood changes, those behavioral changes, the yawning, even the neck pain. So a lot of
Mm,
times people think that neck pain is what's causing the migraine attack, but that's not the case because then it would be a secondary headache again.
yeah.
So what's happening is that there's a connection in the brainstem between the brain and the cervical region, and when it goes to the thalamus and then the cortex, the brain is interpreting it as neck pain when it's not actually neck pain, but it's actually coming from the head, the CNS. But it's because they converge on the same spot. There's referred pain, and so in prodrome, there's neck pain, and people tend to think, oh, okay, because I didn't have the headache part yet of the migraine attack, I felt the neck pain first, and then therefore it's the neck pain causing the headache, when in fact, the migraine attack has already begun. It actually probably
Mm,
begun 24 to 48 hours before the neck pain even initiated. So yeah, all this is prodrome. Um, the hypothalamus is activated 24 to 48 hours before anything even occurs. And so all these changes are occurring. Your brain impacts mood, your brain impacts behavior, satiety. So people tend to eat a lot during prodrome. Of course, not the ones that get nausea and vomiting. It's very individual depending on the patient. But yeah, everything changes. It's a neurological condition that impacts the entire brain.
mm. It's quite incredible because I think, a lot of people don't realize, I know this sounds silly. We know how important our brain is for thinking, but I think a lot of people don't fully realize that it coordinates everything we do. Like you say, our coordination, the way that we taste food. I mean, people get different sense of smells as well, and sometimes in the prodromal phase as well, taste can be different. All of those things that can occur, and it's often affects the whole brain, not just one area of the brain as well. But talk me through what because there's so many different theories as to what happens in the brain with migraine, and just tell me a bit about that.
Yeah, so it's impossible to actually talk about the physiology of migraine because there are so many
Mm,
components.
mm,
The main one right now is the trigeminal vascular system and how that's involved in migraine, but there are so many components that essentially it's currently impossible to pin down exactly what's going on. We would need a quantum computer actually
yeah,
to figure out,
yeah.
or else it would be easy. We would have a receptor. Okay, that's a receptor.
Mm,
Let's block it, and that's the end of migraine. But that's not the case because so many things are involved, especially hormones. There are so many estrogen receptors in the brain, progesterone receptors. Everything is involved in what contributes to a migraine threshold. So it's basically estrogen, erratic estrogen levels, specifically a dip in estrogen, will decrease the migraine attack threshold. So really, so many components are involved. However, the main theory right now is should the trigeminal vascular system, and also for aura specifically, it's cortical spreading depression. So essentially, it's a wave of electricity going across the cortex at a rate of approximately 3 to 6 millimeters per minute. And so this wave of cortical spreading depression, uh, basically it activates the neurons in the glial cells in the brain when they shouldn't be activated. And so that's when you have these aura symptoms. So visual aura, if it happens in the occipital lobe. As it progresses forward, then you get sensory symptoms like paresthesias and language symptoms as well. And also there's a theory that this might also be a component of migraine with brainstem aura as well, or vestibular migraine. And even there's, again, these are all theories because we're not exactly sure, but retinal migraine as well. It's not CSD in the cortex, but CSD in the retinal area of the eye or the neurons near that area. So there are many theories, many components. Thankfully, we finally have a medication that can target one of the receptors that we knew, or actually not just the receptor, it actually targets the protein, and different ones also target the receptor, the CGRP inhibitors or antagonists. And that's just one factor of the vast migraine pathophysiology. And CGRP, for those that don't know, it's calcitonin gene-related peptide. It's a neuroinflammatory peptide that is of significant consequence in migraine patients. In fact, patients that are that have menstrual migraine, if you check their tears, they have an increased level of CGRP in their tears, as opposed to women that don't have menstrual migraine.
Really interesting, isn't it? I think the thing that I learn more and more about migraine is it's multifactorial, as in there's lots of things that can happen. And it's often not one thing. Sometimes, like I know, for example, if I went and ate some chocolate or I went and ate McDonald's burger, I would probably pretty much be guaranteed to get a migraine. But sometimes it's a multitude of little things that can trigger, and that makes it very difficult in management because you can't just say, okay, Louise, never eat chocolate again and you'll never have a migraine. I mean, I don't eat chocolate and I still get migraines, so of course it's not just that. And so in medicine, often we're having to unpick and we're trying to work out, and we're trying to also treat very holistically. And sadly, the way that many of us are taught in medicine is this is the condition, this is the treatment, this is the pathway, you do X, Y, Z. And I think more and more migraine isn't like that because people are very different. And I spend a lot of time really just trying to work out any potential triggers and if there are ones that are easier to avoid than others. And that's the easy bit almost, isn't it? But even when we avoid triggers, it can take a few months to know whether that's had an impact or not. But certainly, obviously, I can't talk to you about migraine and not talk about hormones. And the role of hormones in our brain, and we all know, is very, very important. And the commonest symptoms people have generally, but also in my clinic, are symptoms affecting our brain. So, the mood changes, the memory changes, headaches, really, really, really common. So we know that something's going on in our brains. And actually, a lot of the symptoms are worse in perimenopause, before the hormones are low and stay low. And this sort of crisis time, it used to be described in the 1800s, this time before periods stopped, we know our hormone levels are really fluctuating. But we also see this fluctuation, like you say, people with menstrual migraine, if they have this drop of estrogen and progesterone before their periods. So it's the changing hormone levels that can be really bothersome, as well as, or instead of, the absolute level of hormones. And so talk me through, why do you think it is that these changing hormone levels can trigger migraine for some women?
So it's important to actually talk about why it changes, but also proof that it is the estrogen, right? Because first of all, how do we know it's estrogen? Well, we do know because up until 9 years old, men and women, or girls and boys, generally have an equivalent prevalence of migraine. So men and women, there's no difference in prevalence. However, at about 9 years old, that's when things begin to change. And the prevalence for migraine in women increases drastically compared to men. And so what happens around 9 years old? Well, it's puberty, right? It's menarche. Which is the first menstrual cycle for women or girls. So we have evidence that hormones play a role. So how do we know specifically it's estrogen? Well, we do have examples in regards to menses. If we have, there's something called pure menstrual migraine. There's also menstrual related migraine. Pure menstrual migraine is when you have a migraine attack during your menstrual period, either 3 days before the first day of menses or 2 days after, and that's menstrual migraine. However, if you have it on other days of the month, that's menstrual related migraine. So if you have pure menstrual migraine, that's very common, and so. Well, we see a drop in estrogen. However, we also see a change in progesterone. So how do we know whether it's estradiol or progesterone? Well, in studies, they were actually able to separate the two, and they determined it's actually the drop of estrogen that causes the attack, and it's not the progesterone. In fact, progesterone is protective, which is something that's very important to know. Same with testosterone, and that's why we have this sexual dimorphism when it comes to migraine. So we know that estrogen is the cause. It's well, especially for it, there's a difference between migraine without aura and then migraine with aura. For migraine without aura, it's the drop in estrogen, but they also found that migraine with aura, it's the uh, it's the level of estrogen when it gets too high, then that can trigger an aura. So what's interesting, and during ovulation, there's an LH surge, which causes an increase of estrogen, a dramatic increase in estrogen. And so during ovulation, that's when a lot of aura actually happens in migraine attacks. So it's because of that high estrogen level, because of the LH surge, which ovulation is when the egg releases from the ovary. So when we are talking about migraine without aura, that's that drop. And it's not only migraine without aura. It's not only endogenous changes in estrogen. It's also exogenous changes in estrogen. So if a woman is on IVF, that can also change things. If she has a placebo week, that also can change, especially on the third day. So if there's a placebo week, if you receive hormonal contraceptives with a placebo week, on the third day is when migraine attacks usually start. Interestingly enough, it's also the third day that after childbirth, that migraine attacks also rise again, because the pregnancy, especially the second and third trimester, are protective against migraine. However, after childbirth, if there's no breastfeeding involved, because breastfeeding also maintains estrogen levels, if there's no breastfeeding after the third day, same with the placebo week, third day, there's also a rise in migraine attack incidence. So we know that it's estrogen, and we know that it's the drop in estrogen. And so why does estrogen do this? Well, there are estrogen, it's actually very complicated, and we don't have all the answers. And it's almost as complicated as the pathophysiology of migraine itself. There are receptors in the brain that, and estrogen modulates the trigeminal vascular system. Estrogen modulates CGRP. Estrogen modulates the pain descending pathway. So we have our own internal way of our body to feel less pain. Our body is able to turn off pain signals through the pain descending pathway. Estrogen modulates that. Estrogen impacts serotonin, which is important in migraine pathophysiology. And migraine impacts the opioid system obviously the natural opioid system in our body. So estrogen has so many, it's involved in so much of migraine pathophysiology that, of course, it explains much of the sexual dimorphism that we see with migraine and women.
Yeah, and it's so important. And it's often forgotten because people don't think about it as a brain hormone. They think about it as just regulating our periods. And any changes, like you say, of levels can trigger. And I know often it is related because obviously I spend a lot of time balancing hormones. And when people have their hormones balanced at the right dose, it can be transformational. But often when I see people with migraine, I'm very cautious about giving estradiol, because if I give them the amount they really need, that increase can trigger migraine. So often I go quite slowly, and we even use patches, and we might cut them in a quarter and then go up to a half and then 3/4 and then go up. And that sort of slow increase can be really reap dividends, because also if people aren't on the right dose, if they're maybe on half a patch, they might still get migraines that are worse than they were before.
Hmm.
And then they have to always go through the threshold, and then they're on the right amount. So it's really important. Some people say, no, I can't have hormones because they made my migraines worse. But when you take a detailed history, they've either been on the wrong dose of estradiol, or, which is more common, they've been on contraceptives in the past and think that that's the same as HRT, and they're not, are they?
Exactly. So people generally don't know what kind of hormones they're getting. So hormonal contraception, or combined hormonal contraception, contains synthetic versions of estrogen. And so uh, you would think, oh, so what? It's just one added ethanol group. It's not that serious. No, it's actually very serious. It changes everything. It changes the metabolites that occur. It actually, because so for instance, there's ethinyl estradiol, which is the synthetic, and then there's just estradiol, which is just the natural estrogen. So giving that as a transdermal or a gel um, allows it to, one, it doesn't go to the liver directly, and two, it allows for just a sustained, calm level of estrogen in the body. Meanwhile, if you take the synthetic version, it goes to the liver, and the liver produces actually, so this is actually an important part, which is the clotting risk. The liver produces coagulation factors. And so we have primary, so if we get a cut on our hand, for instance, right away there's primary hemostasis, platelets, von Willebrand factor just come together. But it's if you move your skin a little, you'll bleed. It's not very stable. Then we have the secondary hemostasis, which is what makes the clot stable, right? We want that fibrin mesh. Well, in the secondary hemostasis, where we finally want that fibrin mesh clot to make our clot really, really strong, it depends on coagulation factors. And so one coagulation factor activates the next, and so on and so forth. It's like a domino effect. So these coagulation factors are made by the liver. So what ends up happening is that these synthetic hormonal contraceptive pills go to the liver. So the ethinyl estradiol, for example, goes to the liver. It increases these coagulation factors. Therefore, it puts women in a prothrombotic state.
Mm.
So it gives them a high risk of stroke, when it's not necessary, because they could just take the synthetic, the natural version, which has no proven thrombotic issue or factor. It's just with the synthetic versions. So, and that's not to say that the natural versions don't increase coagulation factors. They do. We know estrogen is prothrombotic regardless, but it doesn't increase it to the extent. It's not clinically important to a level that the synthetic ones increase these coagulation factors. And not only does it increase coagulation factors, we also have a protective mechanisms, protein CNS, also made by the liver. There are anticoagulants. So it also decreases those. So it's a bit of a double whammy with
Yeah.
the synthetic ones. So
Yeah.
not only that, so one, you're getting increased increased risk of thrombosis, which is very dangerous, and especially for women under 50, which is when the increase of thrombosis is pretty serious. After that, it's mostly the cardiovascular risk or cancer risk. But under 50, we're concerned about stroke. We're concerned about a cerebrovascular accident or a cardiovascular issue. So specifically for women under 50, they need to know what type of hormones they're getting. Are they getting the natural, or are they getting the
Mm.
synthetic? If they're getting synthetic, they should ask why. They should ask their provider if they can be on the natural version, maybe a transdermal, especially for women with migraine with aura, where stroke risk is increased significantly more. The issue with the synthetic version as well is that it causes erratic changes in hormone levels. It's not stable, and besides the instability, and yes, they say, okay, well, if you're on it for a longer period of time, it'll stabilize eventually, and that's not always the case. And if it is the case, why is that even necessary to be on such a high dose? when you could just be on a lower dose of the natural one, and because it's less potent, but it causes the stable estrogen that we're looking for, which is vital. So there's absolutely no reason to be on the synthetic one. Ask for the natural estrogen, natural estradiol. That's the key. Also, your body doesn't know how to handle the synthetic version. It creates metabolites that your body really doesn't know what to do with. There's no reason to take a medication that is equivalent of another medication, but your body isn't used to it.
Doesn't make sense, does it?
Right.
Yeah. And it's really important that people know that small change in chemical structure can make a big difference. And sometimes I say to people, if they think about carbon graphite lead pencil and a carbon that made in diamonds. So it's just the graphite carbon pencil and diamond are just made from carbon, that's all. But one has got an extra bond. Just having one extra chemical bond will completely change the structure. You know, I'm very happy having my diamond engagement ring, but I wouldn't want a bit of lead pencil in it instead. But they're still got the same. So just changing something very small in chemistry can make big changes in our bodies as well. And then finally, just before we end, the other hormone that I see clinically, and there is a small amount of evidence, is testosterone. And testosterone is not just a male hormone, it's female as well. And we do produce more testosterone than estradiol when we're younger. But we certainly see that a lot of women who, once they're given testosterone at the right dose for them, their migraines really do often melt away. So testosterone also has a role in the brain, doesn't it?
Right. So testosterone is also protective, something that men take advantage of, and that's why there's that sexual dimorphism again. So yes, testosterone, it's produced by the ovary and the adrenal gland. So women do naturally produce testosterone, and therefore they can naturally have a reduction of testosterone. So they might need to supplement with testosterone if absolutely necessary, and it's protective again. So the testosterone and progesterone are both protective against migraine, which is it's vital for people to know, so they can while there's so the issue with checking FSH and LH and all these and estradiol is that when you do lab work, it's just a snapshot in time. It's not really, you're not really getting the full picture. There's fluctuations, so you can't base any real clinical value based on blood work, unfortunately. However, a lot of migraine treatment is trial and error. So see if it works. If it doesn't, go back to the drawing board, try again. And that's the same with much of migraine treatment.
Yeah, absolutely. And I think it's really important for people to know that, because hormones are only one part of the puzzle, if you like, but they are an important part. And so many people I see have tried everything else but migraine, because a lot of migraine specialists, a lot of neurologists don't even prescribe hormones, so they don't even think about it. And so knowing that there are options is really important. And I'm sure I will invite you back to talk even more, because there's so many aspects of migraine. I could talk all day about it, because as a migraine sufferer, I know when I'm migraine free, it is the best time ever. And it's so important that the knowledge can be shared, so then people can all learn what's right for them, because we're all different.
Absolutely.
So thank you so much for your time. I've really enjoyed talking about it.
Thank you for having me.